Hello, everybody. Welcome back. We're going to move on to our next section, which is when and how to switch therapy. And we're expanding our panel to even be more international. We're having joining us now a lot of the panelists from before, but also Dr. Jenny Hoy from the land down under in Australia. Welcome, Jenny. We also have Davey Smith from the land up under in San Diego, California. He's professor of medicine there at UCSD. And Dr. Jean-Michel Molina, who's from Paris, France. And he just probably attended the new opening of Notre Dame. So Dr. Gandhi is going to lead us through this section, so I'll turn it over to him now.
Great, thank you, Mike, and it's good to be back. We're going to go over to a topic that I think comes up pretty much every day in my clinic, which is when and how to switch, and that includes when and how to switch in people who are doing well on therapy, but for whom there's a reason to simplify it. So hopefully my slides are coming through okay. Here are my, I don't have any relevant financial disclosures. And here we go. So as with all the other sections today, we're going to start with the case. This is a person I saw. He's 50 years old. He has HIV. He was treated with many different regimens for HIV in the 1990s. He has two nucleoside RT inhibitor mutations, the 41 mutation, the M41-184V, and then he has NNRTI mutation, several of them, including the Y181C. Now, this is the important part. He's been suppressed for years on TAF-FTC and a boosted protease inhibitor, but because of drug interactions, he needs some other medicines. You'd like to change his regimen. So the question to you, the audience, and then to our panel is, what would you choose? And so, again, a person suppressed on two nucleosides and a PI. So would you say, nope, really no options here, we're going to have to stick with what he's on, the boosted PI with TAF-FTC? Are you comfortable switching him to TAF-FTC bictegravir? How about boosted protease inhibitor, boosted darunavir plus dolutegravir? Is he going to need 4 drugs to keep him suppressed, TAF-FTC, rilpivirine, and NNRTI plus dolutegravir? Or are you comfortable with cabotegravir rilpivirine? Is this person eligible for injectable therapies? So again, nucleoside resistance, NNRTI resistance, suppressed on a boosted PI. So you've got these choices in front of you. Let's see what people think, and then we'll put our panel on the spot, including some of the discussants that just joined. So it looks like about 3/4 of you are okay with TAF-FTC bictegravir. Some people would like to avoid the nucleosides altogether because of the nucleoside mutations, and would opt for boosted PI and dolutegravir. And then a couple of people, not a lot, but a couple of people are interested in injectable therapy. So maybe I'll ask Dr. Molina, coming to us from Paris, how would you what would you recommend for this patient? And hopefully everyone's microphone is working.
I think Dr. Molina is still at Notre Dame, so we're going to have to wait for him.
Okay. I wish I was with him, but
yeah, me too.
Looks amazing. But how about we turn over to Dr. Davey Smith from UCSD, not quite Paris, but still pretty nice.
I'm actually in Tennessee at the moment visiting my parents, so it is very nice. So how would I approach thinking about changing or not changing?
Yeah, boosted PI, 2 nucleosides, has some nucleoside resistance, but wants to get off the boosted PI. Would you be good with bictegravir, FTC, TAF? Do you want him to stay on the boosted PI? How about nucleoside sparing regimens, boosted PI plus dolutegravir?
This would be where I'd start, would be a good conversation with the patient about what their preference is, and thinking about, if they are thinking about injectable. That's usually the question that I'm getting a lot these days. The resistance to the RTIs worries me, a little bit, and same thing for the NNRTIs, but not as much. And then if they haven't ever been approached by bictegravir before, that would be a question of why they have or haven't been approached by that before. But that would be where I would be leaning.
Yeah, I think those are good points. And maybe Dr. Hoy, I'll ask you next, from even further away than Tennessee.
Notre Dame, correct. So I think this man, the aim is to try to change his regimen because of the drug-drug interactions or potential drug-drug interactions. I would actually like to understand his treatment history, what he's been on before. But I think I'd avoid the injectable cabotegravir rilpivirine at this point, because there is intermediate resistance to the rilpivirine, and that will be a risk factor for potential failure of that regimen in this particular man. You know, you could use well, there is intermediate resistance to rilpivirine. The darunavir cobicistat in both A and C maintains the issue about the drug-drug interactions. And I would actually feel comfortable using TAF FTC bictegravir despite the M184V. So I would be preferring the B.
I think there are no data and relatively new data that led our guidelines panel to essentially conclude the same. Maybe I'll ask, can you see my slides, or are you seeing, what are you, Jenny, can you see my slides right now?
I can see your slides.
Okay,
I can see the audience and panel question. Yeah.
Terrific. Okay. So this iteration of the guidelines makes the point that there are several reasons that we might consider switching therapy. For example, in a person on a regimen, as in the case I'm presenting, where there's anticipated drug interactions, adverse event effects, inconvenience, etc., and even cost can be a consideration. In that instance, we recommend switching to one of the recommended initial therapies, of course, provided that you can maintain viral suppression. And I think that's the crux of it. Is there are new data now that in people like the patient I'm presenting, a person on a boosted PI and 2 nucleosides who's virologically suppressed, there are 3 good studies saying that we can switch to dolutegravir plus tenofovir FTC or 3TC or bictegravir FTC TAF, as long as they don't have integrase resistance. They can have some nucleoside resistance, and I'll show you some of the data that support this recommendation. But if they don't have integrase resistance, and our patient did not, then this type of person who's suppressed can safely be switched over. The options for switching over include what we call the high barrier to resistance integrase inhibitors, things like dolutegravir and bictegravir. We do want, we would suggest monitoring closely in that first year, but we don't suggest using a lower barrier to resistance drug like raltegravir, elvitegravir, because there are some data that those are less able to keep the virus under control. And so the data in the last few years that do support that are upcoming. I would agree with what Dr. Smith and Dr. Hoy said about cabotegravir rilpivirine. This particular patient has a resistance mutation to rilpivirine. That was the Y181C. And that's where it's a good idea to avoid using cabotegravir rilpivirine, because one of the biggest risk factors for losing control is having rilpivirine resistance. So here are the data that I was alluding to that led to the guidelines change. In a person who's suppressed, like my patient, with nucleoside, 2 studies. One is called the 2SD study, and the other is called the GESCO study. These are randomized studies showing that people stay suppressed if you switch them over to dolutegravir or bictegravir, tenofovir, and FTC. And as Dr. Hoyt just mentioned, if you just have one M184V, there's a lot of evidence that you're going to do fine with bictegravir FTC TAF. I won't go through this in detail because I want to give the panel, we want to dig into a number of other cases as well as come back to our panel. But just briefly, these are manufacturers sponsored study looking at switching people with M184V if they're suppressed over to bictegravir FTC TAF. About 182 people were in that category right here. Out of 1,800 total in the switch study. But of those 182 people, you can see all these bars are close to 100% in terms of maintaining viral suppression. And this is why the US FDA has endorsed using bictegravir FTC TAF in people who have an M184V if they're virologically suppressed on another regimen. Here's that same 2SD study, a randomized study in Africa. These participants were all suppressed, kind of like my patient, on a boosted PI plus 2 nucleosides. And what these red and green kind of holiday colors are showing is that switching over to dolutegravir plus 2 nucleosides was just as good as continuing the boosted PI. And then a really remarkable study, not yet published but presented, done in Haiti during the worst, some of the worst of the violence in Haiti, done at Guesquio in Port-au-Prince. 300 people with HIV. They all had some nucleoside resistance because they had failed a first-line regimen, but then were suppressed on a boosted PI. And what you're seeing here is they were randomized to either stay on their PI or to switch to bictegravir FTC-TAF, and 95% rates of virologic suppression. So I think it's safe to counsel this patient. We would want to monitor him, of course, but we could switch over to bictegravir FTC-TAF. And I think that's what 75% or so of you said as well. I'm going to see if our panel has any other comments before we go to a different case. I'm having trouble seeing both the panel and my slides. So
Raj, I just would like to add that the Haiti
Yeah.
study reinforces a couple of other studies from resource-limited settings in Africa that also do suggest that in people who are failing, in that case of NNTI based regimens, do well with switching to dolutegravir plus TDF FTC, even if they did have even K65R in that instance. So that is relatively safe.
Yeah, I thank you, Dr. Bedimo. I mean, there has been a sea change, I would say, in our understanding of resistance in the last 5 to 7 years. And what studies that were mentioned, the Nadia study, the Vicen study, and a study also out of sub-Saharan Africa, really have shown us that when you have a lot of nucleoside resistance, still in most instances, dolutegravir FTC-TAF or bictegravir FTC-TAF should be active. There was also a study called the DEF study, which was done it was done in Australia actually, and parts of Southeast Asia, showing the same thing. So a lot of good data supporting these recommendations. Are there any other comments before we switch gears to?
Maybe one comment from my side. I mean, I fully agree what has been said, but still, you know, if there is a little bit of adherence issues, I would be very careful, because there is also data clearly showing that if you have nuke resistance, you know, and then you have a failure, you have more likely integrase resistance. So I think it's good studies, you know, but I mean, all cases I have seen with integrase resistance have had nuke resistance.
Yeah, and that's a good point. We are watching the data coming out of Africa with some amount of dolutegravir resistance, and one of the risk factors is just as Dr. Günthard said, which is having nucleoside resistance. So it's not fail-safe, meaning you can't do it without careful thought. But as long as people are monitored, I've had good success. So I think that the two things are true. We have better data with the switch, but we still need to monitor. So, all right, let's switch over to and again, someone will stop me if because like I said, I can see my slides, but I can't see all of you, so I apologize for that. So this is a very common scenario. I would say this happens almost every week. 50-year-old woman with HIV. Her CD4 count is 500. Her HV RNA is 500,000. She doesn't have resistance mutations on her pre-ART genotype. She does have gastroesophageal reflux disease and sometimes takes over-the-counter therapies for that. She started on bictegravir FTC-TAF, and her HV RNA declines to 100 copies per mil, but then just gets stuck. Basically, over the next year, and even a bit longer now, her viral load just keeps fluctuating between 55 to 100. It doesn't go up, but it also doesn't go down. So she's got low-level viremia. So what would you do in this instance? And I'm going to ask you to go ahead and vote. Would you add a drug? Would you add an NNRTI, a doravirine? Would you change your regimen to a boosted protease inhibitor, TAF-FTC, because you're worried about resistance? Would you evaluate her for drug-drug interactions, or would you send a proviral resistance genotype? There was a question earlier in the webinar about that last point. So which of these four would you do? And I'll look forward to your comments, and let me see if I can figure out how to see the panel at the same time. Okay, looks like our audience about again, 3/4 are interested in making sure that there's not a drug-drug interaction. They also picked up on that gastroesophageal reflux disease and maybe wondering what the person's taking. And then we're going to talk a bit about proviral genotype, and I'll ask Dr. Smith to say a few words, but I'll also share some thoughts. But what does our panel think? And I'm going to look and see if I can see the panel, but go ahead and what does our panel think about these choices that the audience is voting for? And how would you manage this?
Perhaps I can jump in, Dr. Gandhi.
Please.
So I agree with the audience. The first thing I would do is evaluate drug-drug interactions, and mostly because he's experiencing some additional disease and we don't know the treatment. So it's important always to have the checker with us and see and do a good evaluation and interrogation to our patient. But the second thought that I have is that adding some additional antiretroviral has been studied in the past and not there's no benefit on that. And with the low level viremia, I'm not the expert. Dr. Huldrych is the expert, so I wonder what his thoughts are. But for now, I would evaluate if he's not taking something for that has a magnesium or calcium that can interact with the absorption of the ART.
Good points. And maybe I'll ask Dr. Günthard first, and then Dr. Smith, and then we'll, and Brenda, maybe I can ask you, are you seeing just one slide right now or two? Are you seeing my next slide or just one?
I'm seeing both, so it's
we
not
see both.
as a percentage.
Okay.
Yeah.
You need to go, you need to change
Is it perfect now?
Yeah, no.
Yes, now it's good.
Okay, good. I can see you and I can see my slide, so everything is good. How about you, Dr. Günthard? What do you think about this patient?
As basically it has been said, you know, that there is actually, I think there's no data to add on something, you know. But on the other hand, we just published a paper right some days ago in CID from the Swiss HIV cohort study where we showed that actually low-level viremia is a major risk factor for treatment failure. You know, it's not just nothing. And it was actually the strongest risk factor for failure in a very well controlled patient population, 8,000 patients over many years. And what was also fascinating in that study was that when we introduced integrase inhibitors, the frequency of low-level viremia went down. You know, it's not just nothing. Not every low-level viremia is some cells producing maybe aberrant viruses. So I think we just have to monitor these people, and as has been said, to rule out drug-drug interactions. In my place, we would do a drug level to maybe even reinforce whether we have a problem. But otherwise, I think monitoring is what we should do.
Great. Dr. Smith, you get
Yeah,
word and
I
then
also do agree with Brenda that, you know, one of the things that we worry a lot about here on this side of the Atlantic, I don't know about over there, Huldrych, is multivitamins that people take over the counter a lot. Now, they contain divalent cations that are very good at clearing these integrase inhibitors. So in this kind of low-level viremias, I will make sure that person is not taking multivitamins. Now, they have reflux, so I guess what people may wonder is whether PPIs could be a problem, but he's not taking either ribavirin or tazavir, so I don't think that that would be an issue, but they probably are taking other things like multivitamins.
calcium, good point. Dr. Smith, you're the last word. What do you think about proviral genotyping? A fan, not a fan, or depends on
I'm becoming less and less of a fan. And in this situation, I don't think that it would be appropriate. So really just getting at the drug-drug interactions, like everybody said, this is the classic case. I see this quite often. And sometimes it's on me, for one, not talking about adherence, and then also not going through all the vitamins and over-the-counter stuff that people might be taking.
Yeah, I think that's right. As Davey said, adherence is the other thing when you talk to the patient about, right? Because a lot of these patients may have, you know, problems with adherence, maybe not taking their medications, but just having a frank discussion and getting an idea. Frequently, patients don't see multivitamins as medications, so they don't tell us about them.
So I think all the high points have been hit, so I'll be brief. Adherence, I think, is important to assess. Sometimes pharmacy refills help. I thought Dr. Bedimo was going to mention zinc, which is in bodybuilding supplements, but here the patient was taking calcium, and that was, Tums basically, which was the cause.
They
of the
also
problem.
use zinc for COVID, so that's
That's right. We lived through that era. Viremia due to intercurrent illness is usually transient, and this person hasn't been, hasn't had an illness that long. Malabsorption really is very rare. And Dr. Günthard said this, at the end of the day, I have a few people where I have concluded that the low level viremia is due to release of virions without ongoing replication, but that's really a diagnosis of exclusion. You've got to look for other things. And then adding drugs really doesn't appear to help. So.
Just briefly,
Mike, want to jump here? Yeah.
Yeah, just briefly, Raj. This is it's biology, as you just alluded to. People that have had a high baseline viral load prior to initiation of therapy, like this person did, there's a larger reservoir, and there's just this background virus that's being produced from a reservoir. It does not mean that there's ongoing de novo replication. We all have a fair number of patients who are like this. So look for the interactions, but this is probably biology.
I'm going to say one word about proviral genotyping because this comes up also quite frequently. So what's a proviral genotype, first of all? It's when you look at not the RNA, not the HV RNA, because you need at least about 500 copies to do an RNA genotype commercially. But you look at the DNA, that's the provirus. It turns out, we've known this for a while, 90% of HIV DNA proviruses are defective and not replication competent. But there's also a sensitivity issue with the proviral genotype. In one study, they had 100 people who had the M184V mutation that confers 3TC resistance, and they did a proviral genotype, and only 50% of the time did they see it. But these were people who had, a historic M184Vs. And then even more recently, that data is published, but even more recently at CROI in 2024, there was a group that did longitudinal proviral genotyping, and half of the time, there was variable detection on the proviral genotype of mutations. That means at one time point they saw it. These were all people on ART. At another time point they didn't. So again, the sensitivity issue is a consideration. It's also not validated. So I don't send the test very often. If I do find a mutation, it's hard to completely ignore it, but I generally try to use this very sparingly. If a mutation isn't detected, you can't be sure that it's not there. And so let's go on to our second case. And this is a person with substance use disorder. He was diagnosed with HIV in the 1990s. At the time, he was on efavirenz, FTC, TDF. He did develop the K103N mutation in his HIV, so an efavirenz mutation. He's not hepatitis B positive. He's having trouble remembering to take oral medicines. CD4 count's pretty high, is 500. His HV RNA is 20,000, and he asks about injectable cabotegravir rilpivirine. So let's see what our audience thinks. Would you go for injectable cabotegravir rilpivirine? Yes. B is no, or C is it depends. And you can put into the chat or into the Q&A what those considerations are. So let's see what our audience is feeling. Okay, looks like 1/3, 1/3, 1/3. So perfect question for our panel. How would you approach this patient? Let's see, I'm looking at the Zoom to see if I can see any smiles or anything. Jenny, you're smiling.
I would say it depends. I'd like to know a little bit more about the substance use disorder and whether that is creating some chaos in this man's life, and whether we could support him taking oral medication. I think anybody who asks about injectable long-acting antiretroviral treatment, we should be supporting them to achieve that. In Australia, we can't actually get long-acting cabotegravir and rilpivirine unless somebody is suppressed. It's only available on the pharmaceutical benefits schedule for suppressed people. So that makes it difficult for us. And so I would be trying some other processes, supports for this man to achieve virological suppression, and then talk about injectable treatment with
Perfect.
him.
That's great. Maybe
Yeah.
I'm realizing the time, so
I'll-
let's take one more comment, maybe from Dr. Bedimo.
Yeah, I guess
I'll sum
I'll
up
say
the
a couple of things about this patient. One is, would that technically work on that regimen? And I think that we are familiar with 3 different predictors of failure of this regimen, one of which is ribavirin resistance or low ribavirin exposure. But in this instance, K103N would not qualify for ribavirin resistance. There's 2 others being subtypes A1 or A6, but new data in Africa suggests that it may not be as important as what was seen in Atlas and Flare studies. And the third one will be the BMI, which we're not given here. So it's likely that ribavirin cabotegravir will work, but in somebody who's viremic, I know that right now we are recommending the consideration in case nothing else would work and the person is already has advanced disease or would otherwise not do well, like with very low CD4 count. But this person has a CD4 count of 500, and I haven't gotten any sense of desperation yet.
Yeah, I think that last point is a really important one. I'm going to show you our latest recommendations, but it really is reserved for people who just can't take an oral regimen, but also have risk factors for life-threatening complications, CD4 count less than 200, or AIDS-related conditions. So let's go through this, and then we'll open it up. There's a number of questions I see, so I won't go too long. I think this point has already been made by Dr. Bedimo about the risk factors. This person has the K103N mutation, but that isn't a rilpivirine mutation. In Atlas and Flare, there was about 24 people, not a very large number of people who had K103N. They weren't excluded, but it's also hard to be super confident that there's not some rilpivirine resistance hiding in the background. There are new data from the AIDS clinical trials group supporting the use of injectable therapy in people who have trouble adhering to oral therapy. And these data, though, people were given conditional incentives, financial incentives to get suppressed, and then were randomized to injectable therapy or oral therapy. And there was a better outcome with injectable therapy, but they did get to suppression first. There are some demonstration projects, they're shown here, I won't go through them in detail, that also support that if you are in a very difficult situation with a low CD4 count, there are some supportive data that you can use this, but again, this person isn't in that category. So this is where the IAS-USA ended up, which is in those who are not able to take oral ART if you've got advanced disease. With case management, adherence support, it's a case-by-case determination, but if the CD4 count's low, we do recommend this given the stakes. And it's not the medicine alone, it's really the medicine plus the support. If they have substance use disorder, treating that with the mental illness, and that's what happened here. This patient actually was referred for substance use disorder treatment, resumed taking oral therapy, and actually did get HIV suppressed. So I'm going to leave it there for now and see what questions we have, and thank our panel for their comments.
Yeah, thanks, Raj. We do have a number of questions or comments. The first one is, in that first case, why do anything with such a low viral load? And I think that's a good point. What are your thoughts?
Yeah, I think that's right. I have maybe a handful of patients who've been living between 50 to 100 for a decade now. And so I do tick through every time I see them. Are you taking the big 4 multivalent cations? Are you refilling your prescriptions? But I don't change them. I certainly don't add drugs. I think Huldrich's study and others show that we shouldn't assume that to be the case, but once we're convinced and we've gone through the due diligence and we've been monitoring them, then I don't switch.
Yeah, and Brandon sort of reinforces what we were saying about proviral genotype having a low sensitivity, and it's really as misleading as it is helpful. I personally don't really use it, but his recommendation is just to, if you're going to switch to cabotegravir rilpivirine, just keep checking the viral load frequently at the beginning just to make sure, because there's a lot of patients, as he points out, who show up without any background information.
In that
Yeah.
regard, I can say when I switch people to cabotegravir rilpivirine, for the first few injections, I check their viral load frequently every 2 months because they're coming in every 2 months. But there are data from Africa saying that once people are suppressed, really every 6 months is probably enough. I don't do that at the beginning. I want to, get that extra assurance, especially if there's any question about resistance. So every 2 months at the beginning, but eventually, most people who fail cabotegravir rilpivirine will do so in the first 6 months or so, roughly 6 to 9 months.
Yeah. A related question from Ron, talking about the caveats of proviral DNA, like in this patient who has a K103N, who's wanting or needs to go on cabotegravir rilpivirine, should we do the proviral DNA just to see if there might be some additional proviral DNA?
That person was viremic at the time, so that way you don't need to do the. In fact, I don't do a proviral genotyping if the person's viral load is over 500. I do just a regular old RNA genotyping. So that's a good point.
Mike, you're mute.
Oh, I don't know how that happened. Okay, I'm back. So Kristen Wagner asked about, is it common for us to see patients for whom we do not have full antiretroviral history? That is the case. And about switching to dolutegravir 3TC in this scenario, without a full history.
I saw Dr. Crabtree smiling. People are going to be careful about smiling on this. Do you want to comment on dolutegravir 3TC and someone that you don't have a complete treatment history in?
Well, I think we don't have the data to support that decision. I think it is risky to have only dolutegravir 3TC as a regimen in those in which you don't have the history, and they have, although they are have been with several regimens before. So I would be careful with that decision, unless somebody else has another opinion. We don't have, for example, proviral genotyping, so in most of the world doesn't have access to that. So we have to do decisions according to the history that we have. So I would choose something more safe, and don't do dual therapy in this case.
Okay. Arthur Moswin is raising the point that they have started in their clinic a number of patients on straight up cabrilpivirine when the viral loads are detectable, but usually at about 1,000, 2,000, and says that they've been very lucky and most everybody suppresses. And then brings back the comment about the Ward 86 San Francisco general experience, which was generally positive. However, about 15%, maybe 20% did not have success. So does that give you pause?
And also the question about viral load. Huldrych, I saw you trying to get a word in. Did you want to comment on this, or were you? I can give my opinion on this in a second, but
You mean me?
we can hear you now. Yeah,
Yeah,
little soft though, but maybe
I
speak
just
loudly.
wanted to make a comment on the profile DNA test. Something we did not mention is that you can also overestimate mutations, because if you don't correct for APOPEC-induced mutations, you find quite some integrase mutations, which are caused by APOPEC 3G, and also some NNRTI mutations. So you can find mutations which are just wrong. So it's even more complicated. So I would not use profile DNA most of the time. So
to the Ward 86 experience, the median viral load in that study was about 16,000 or so. So it was not as high as some of our patients. There was a very small, admittedly small case series from Mississippi of only 12 participants, and there sometimes the viral load was as high as 150,000. And again, fairly short-term follow-up with good results. But I agree that it's one of those things that it's totally case by case, and you have to be especially careful for sure. So.
And then this last question about what would you do if you don't have any background genetic information, genotypes? I guess in the setting for cabotegravir rilpivirine, and this would, I guess, not be the case where you have somebody on therapy where you could probably get something before you switch. But thoughts in that situation?
when you really don't have any history, they're on a medication that's working.
Yeah.
How do you proceed? I don't know, Carlos, Dr. Elbria, have you come up with this situation where someone new to clinic, you just can't get records, they're suppressed, and how comfortable would you be with cabotegravir or rilpivirine there?
You know, that happens all the time, and I think you get a little antsy when you have somebody who is, you know, one of those long-term patients who you know has been on therapy. I mean, if you've been alive since, I don't know, the early 1990s, you for sure went through ACT and a bunch of, you know, efavirenz and a bunch of other drugs. Even though I may not have your records, I pretty much know by when you were diagnosed what you were on, and you can reconstruct that, and therefore you get a little more nervous about starting. If you have somebody who's recently diagnosed and you know you didn't have that exposure, it's a lot easier to make the decision.
Yeah, I'll say I was presented a case recently where we had no history other than the patient remembered they'd been on etravirine. That person had gone through a lot of nucleus and an RTIs, and so so I was nervous about using cabotegravir or rilpivirine, even though I couldn't prove they were resistant. You don't generally get the etravirine unless you've gone through efavirenz first. So yeah.
Okay, well, we're over the time. Dr. Gandhi, I will turn it back to you for the next section.